Hello students, hope you're all doing great. In this video, we're going to discuss about fetal assessment. Okay. So, fetal assessment. See, fetal assessment or using some of the methods to monitor the well-being of the fetus when the fetus is in utero itself. Okay. So, that will be intervening when necessary and will be planning the management of the pregnancy and labor accordingly. Okay, and this will be commencing mostly after the period of viability. Clear? Yes. So, this is nothing but assessment of fetal well-being during pregnancy especially after the period of viability. Okay. See, why this is important means antepartum fetal death is more common than intrapartum fetal death. Okay. So, this justifies that there should be some mode of fetal monitoring throughout the pregnancy till the baby is delivered. Okay. And also, remember the primary goals of fetal assessment include number 1, as we have discussed, to prevent fetal demise, and then we have to reduce the perinatal mortality and morbidity as well. Okay, to reduce the perinatal mortality and morbidity as well. Okay, right. Now we'll see the intrapartum fetal surveillance. Okay, so why it is necessary? See, normally during intrapartum period, that is when the woman is in labor, what is going to happen? There are uterine contractions going to happen. When the uterus is going to contract, it is going to deliver only less blood supply to the fetus because there are compression of the blood vessels. Okay. So, normally a fetus which is healthy will overcome the stress and it will tolerate this state of hypoxia. But when there is a compromised fetus, like if it is a fetal growth restriction is present, or if there is a preterm baby, in these cases, or already there is a chronic uteroplacental insufficiency, in all these cases what is going to happen is the fetus will not be able to tolerate the stress for a longer time. See, what is going to happen in this intrapartum period? Uterine contractions are going to happen. These uterine contractions are going to compress the blood vessels in the uterus, and through these blood vessels only nutrients and oxygen is going to get supplied to the fetus, right? So, when the uterus is getting compressed and this state of insult is happening, a normal fetus will overcome the state of hypoxia and it will survive and it will progress through the labor also normally. But when there is a compromised fetus, for example, when there is a FGR fetus or when there is a preterm fetus or when there is a state of chronic uteroplacental insufficiency, the fetus will not be able to tolerate this insult. So, what it does it will be going to compromise itself. Okay, so there will be so much of changes that will be happening. There will be hypercarbia, there will be acidosis, and finally it will result in the fetal death. Okay, so intrapartum fetal surveillance is also important, right? So, as we have discussed, normal fetus tolerates the contraction and there is no hypoxia, whereas a compromised fetus, example as I have told, if it is a FGR or preterm baby, it is going to be affected by the insult, okay, affected by the insult, and that will result in fetal hypoxia and this can even result in brain injury. Clear? Now, what are the methods for antepartum fetal surveillance? So, when you take antepartum fetal surveillance methods, these include number 1, maternal evaluation of fetal activity. Then we can go for a Nonstress test and we can go for a biophysical profile. Usually nowadays we use the modified biophysical profile, and then we can even go to study the Doppler. Okay. Next one, we'll go for the intrapartum fetal surveillance methods. Okay. So these include intermittent auscultation, corticotocogram, then fetal scalp stimulation as well as fetal scalp blood sampling, and then fetal pulse oximetry. We can also include fetal echo in the antepartum as well as the intrapartum period. Clear? Yes. Now, I'll just tell you what is going to happen when there is a chronic fetal compromise. Okay, so this overall idea will help you in understanding the upcoming points. Clear? Right. Now, let us see what is happening during chronic fetal compromise. So, first thing is, there is a uteroplacental insufficiency. When there is uteroplacental insufficiency, there is reduced supply of oxygen to fetal central nervous system. Yes, and this will cause, see why this redistribution of fetal cardiac output happens. Because whenever a fetus is getting compromised, mostly it tries to safeguard the vital organs for the fetus. Okay, so what is going to happen is, there is reduced flow of blood to the periphery and viscera, and there is an increased blood flow to the CNS and heart. Clear? So, because of this reduced blood flow to the periphery and viscera, what is going to happen? Again, we have so many factors acting here. Like, first one, there is decreased visceral circulation. Yes, because of this, there will be increase in the umbilical vessels resistance, and then there will be decreased perfusion to the kidney, that is, there is reduced renal perfusion. So, that will result in oligohydramnios. And what happens here is, there is increased level of carbon dioxide and decreased level of oxygen. Also, there will be accumulation of lactic acid. So, increased lactic acid accumulation. So, that will be resulting in a state of acidemia, okay, or acidosis. Clear? So, this is what is going to happen when the fetus is going to get compromised. Okay. So, with this idea, we will see the investigations now. So, first thing what I want to discuss with you is fetal body movements. Okay. So, fetal movements. See, when there is normal fetal body movements, good muscle tone, and breathing pattern of the fetus is also normal. Most of the times there will be absence of any of the hypoxia or acidemia. Okay, so this concept you have to keep it in mind. So, presence of body movements, then fetal muscle tone that is normal, and breathing movements rules out hypoxia and acidemia in the fetus. Clear? Then also remember, especially in the third trimester, we'll have some fetal behavioral status. Okay, let us see these status. So, this will help you to know more about the fetal patterns in the third trimester. Okay, we'll see all these states now. So, state 1F, which is a state of quiet sleep. However, you will see rapid eye movements and repetitive mouthing movements as well. Okay, and the next one is state 2F. This is a state of active sleeping. However, movements are seen. Okay, then you will also be able to see a wider oscillation in the fetal heart rate. And the next state, that is state 3F, you will be having continuous eye movements. Okay, you have continuous eye movements but absence of body movements. Okay, however, the existence of this stage is disputed. Then state 4F, this is a actively awake state. You will be able to see a high range of voluntary activity. Also, you will be able to see continuous eye activity and fetal heart rate accelerations can be seen. So, remember one fact that whenever fetal body movements occurs, it is accompanied by accelerations in your NST. Clear? Yes. Next one is, I want to discuss about another important point, that is fetal movement count. Okay. So, fetal movement count. See, usually fetal movement count can be checked either by ultrasonogram, but what they say is the movements that are perceived by the mother also has a 88% sensitivity to the fetal movement count that is perceived in the ultrasonogram. Okay, so it is said that mothers perceive 88% of fetal movements seen in ultrasonogram. Okay, so whenever there is loss of fetal movements by the mother, there will also be disappearance of fetal heart rate in the next 24 hours. Clear? And remember the fact that whenever the mother is starving or fasting, so maternal hypoglycemia is associated with increased fetal movements. And the fetal movements are reduced during fetal sleep, as we have already discussed. Then when there is fetal anomalies, okay, and it will not be perceived much in case of hydramnios, obesity, or when there is hypoxia. Clear? Yes. Now, what is quickening? Quickening is the perception of fetal movements for the first time in a mother. Okay. So, perception of fetal body movements for the first time. Okay. By the mother. And this is usually around 20 weeks in a primigravida, and it will occur much earlier in case of multigravida. Clear? Yes. Now, how much movements a mother can perceive? See, let us take the mother is at rest. Okay. Suppose the mother is at rest. Then, ideally, she should perceive 10 fetal movements in 2 hours. Okay. Or at least 4 fetal movements in 1 hour. Clear? Next one, suppose if the mother has continuous normal activity, okay, then she should perceive 10 fetal movements during 12-hour period. Clear? Yes. Now, what is the advantage of this fetal movement count by the mother? Okay. So, the advantages is that it is simple and inexpensive. Yes. And we also have disadvantages. The disadvantage is that only the gross body movements of the fetus is perceived by the mother. Okay. Only gross fetal movements are perceived. Clear? Now, we'll go to the another important topic, non-stress testing. Okay. So, what is non-stress testing? That is NST. See, this test will be known as NST, that is non-stress test, when it is done antenatally. Okay. Antenatally means the woman is not in labor, right? And mostly antenatal period will be detecting only the fetal heart rate by this test. Clear? And the same test will be called as corticotocogram when this is used in intrapartum, that is during labor, that is when the uterine contractions are present. So, here we will be monitoring fetal heart rate plus the uterine contractions also. Clear? Okay. Now, remember, usually I have told you already that any fetal body movement is associated with accelerations, and that is going to depict the well-being of the fetus, or the fetus is normal. Clear? Now, what is the technique you should follow while putting NST or CTG? So, I'll tell you some basic steps. Number 1, you have to put the mother in left lateral position. Number 2, you have to give continuous electronic fetal monitoring for 40 minutes. Number 3, mother provided with the indicator. So, she will be pressing that indicator whenever she perceives the fetal movements. Okay, presses it when she perceives the fetal movements. Okay, and also remember, when you put CTG, that is the NST is monitored during labor. You can have 2 types of CTG, that is there can be external CTG monitoring or internal CTG monitoring. Okay, so what is external CTG monitoring means? You will be keeping the ultrasound transducer over the abdomen. Okay, so this transducer will pick up the baby's heartbeat. Okay, now here we'll be recording the heartbeat. In a strip of paper continuously. Okay. Also, we'll be giving a tokogram. This is a pressure gauge that measures the frequency of uterine contractions. Yes. Now coming to internal CTG. So internal CTG can be used only if the membranes are ruptured. Okay. So used only if the membranes are ruptured either spontaneously or artificially. Okay. And what we'll be doing is we'll be keeping an electrode directly to the fetal scalp here. Okay. So that will be monitoring the fetal heart rate. Okay. So this electrode is called as fetal scalp electrode. Clear? Yes. Okay. Let's see this pic. You will understand it better. See, this is a internal monitoring of the CTG. Okay. So what we are going to do is we are going to pass the electrode through the vagina and it will be kept on the fetal scalp. Okay. And this electrode is known as a fetal scalp electrode. Whereas this is an external monitoring of the CTG where we are putting a ultrasound transducer and a tokogram. Okay. So this is the ultrasound transducer actually. So this is kept on the fetus. Okay. Kept near to the fetal heartbeat. Okay. Whereas this is a tokogram that is kept on the uterus to monitor the frequency of uterine contractions. Clear? I hope you would have understood this. See, while studying a CTG or NST, you should know some basic features. Okay. So, you have to know about the fetal heart rate. Then, you have to know about baseline variability. Accelerations and decelerations. Clear? Okay, we will see one by one all these 4 parameters so that we will be understanding. So, first we will see about baseline fetal heart rate. See, the baseline fetal heart rate, normal ranges between 110 to 160 beats per minute. Okay. When it is less than 110 beats per minute, then definitely it is going to be a fetal bradycardia. Yes, and when it is more than 160 beats per minute, it is going to be a fetal tachycardia, right? Then we'll see about baseline variability. Baseline variability is a parameter that is depicting the function of autonomic nervous system of the fetus. Okay, basically in this variability you will be seeing oscillations that is above and below the baseline, and the normal range of variability is between 5 to 25 beats per minute. Okay, so if you see this picture, you will be able to understand. So I am going to show you the baseline fetal heart rate as well as the variability here. See, this is the baseline. Okay, can you able to see, like it is being maintained, right? So this line is being maintained. So this line you have to track. Okay, and it is lying between, it should lie between 110 to 160. Okay, so this is a normal fetal heartbeat range, and these oscillations, okay, up and down, up and down, up and down is going, no? So this is variability, and this variability should lie between 5 to 10 beats per minute. Okay, so first of all, remember the fact that NST paper is running at a speed of 1 centimeter per minute. Okay, so this is the monitoring of uterine contractions that they have given here. See, if you see here, we have 1, 2, 3, 4, 5, 6, 7, 8, 9 and 10 boxes. That means they have monitored for 10 minutes, and this peak represents there is a contraction. So there are 2 uterine contractions in 10 minutes. Clear? So this is about baseline, variability and uterine contractions. Now we'll go to see about the accelerations. So accelerations can vary according to the gestational age. Okay, so if the gestational age is more than 32 weeks, the peak of acceleration is 15 beats per minute above the baseline. Okay, and it should last for minimum 15 seconds, and it can last even up to 2 minutes. Okay, suppose if the gestational age is less than 32 weeks, then the peak can be 10 beats per minute above the baseline, and it can last for 10 seconds or more. So what you have to understand is, when the gestational age is less, that is it is less than 32 weeks, means even 10 beats per minute for 10 seconds of acceleration is also considered to be normal. Clear? So this is a picture of acceleration. See, what I meant as baseline is this one. Okay, this straight line is baseline, and what I meant as variability is this thing. Okay, and what I am meaning acceleration is this thing. Okay, so what it has risen above. So because it has risen above 15 beats per minute, and it has lasted for a longer time also, 15 seconds. Clear? Yes. So this one you have to understand. And we'll see about the decelerations. See, decelerations or the abrupt reduction in fetal heart rate. Okay, so there is a decrease in fetal heart rate, and sometimes it can be gradual also. So gradual or abrupt reduction in the fetal heart rate, that is lasting for 15 seconds to 20 minutes even, and there can be a decrease in fetal heart rate up to 15 beats per minute. Clear? Now in decelerations, you have 3 types. Okay, that is early deceleration, late deceleration and variable deceleration. Now remember the cause alone. Early decelerations are due to head compressions, okay, and these are considered as a normal activity seen, okay. So that is nothing pathological about this. And in late deceleration, if it is seen, it is due to uteroplacental insufficiency, and variable deceleration is due to cord compression. Okay. So this is an example of early deceleration. Okay. See, this is the uterine contraction. Okay. So during every peak of uterine contraction, you are able to see a deceleration. So this peak you have to match and this peak you have to match. If it is exactly coinciding, then it is early deceleration. Okay. So this peak is referred as nadir in textbooks. It means that the lowest point of the fetal heartbeat recorded. Okay. Then this is variable decelerations. Usually variable decelerations doesn't have any orientation with the uterine contractions. Okay. It will occur early, it may occur late. Okay. So will not be able to predict that. Okay. Whereas in late decelerations, if you see, the nadir will not be exactly coinciding with the nadir of the uterine contractions. Clear? So this is an example of late deceleration, and this is an example of variable deceleration, and this is an example of early deceleration where the nadirs are meeting. Okay. So if you are able to rule out what is early and what is late, then obviously you will be able to come out with variable deceleration. Clear? And also remember, we also have a type of prolonged deceleration also. Okay. So what happens in prolonged decelerations means the decelerations last between 2 to 10 minutes. Okay. So it will last more than 2 minutes. Okay. That is prolonged deceleration. Then if it is prolonged and it is seen for more than 10 minutes means it is considered as a state of fetal bradycardia. Okay. So causes of prolonged deceleration include cord compression or acute placental insufficiency or hypotension in the fetus. Okay. So I have an example for that. So this is an example for prolonged deceleration. Okay. So the deceleration is continuing for a longer time. Okay. Are you able to see? So this is an example of prolonged deceleration, and you have to rule out all the other factors. Okay. And also we have one more pattern, that is a sinusoidal pattern. Here you will be able to see a smooth sine wave like undulating pattern like this. Okay. And this will be seen with a cycle frequency of 3 to 5 per minute, and it may persist for 20 minutes or above. Clear? Okay. And the causes for sinusoidal pattern includes twin to twin transfusion syndrome or RH incompatibility. Okay, usually it is seen in cases of fetal anemia. It is taken as an indicator of fetal anemia. Okay. So this is an example of sinusoidal wave pattern of NST seen. Okay. Yes. So once again I will come up with this terminologies and the pictorial representation so that it will be easy for you to understand. So this is the fetal heart rate acceleration. Okay. You will be having only a upgrading slope. Okay. This is early deceleration where it will be syncing with the uterine contraction. And late deceleration, it will be just happening after the uterine contraction. Okay. And variable deceleration, usually you don't have any linkage with the uterine contraction. Clear? Yes. Also remember, in variable decelerations, you have so many types of variable decelerations. Okay. So, you can have a normal soldiering type of variable deceleration. Normal soldiering means this peak. Okay. So, this is the normal soldiering. Whereas, this is a overshoot soldiering. The soldier that is happening here has overshooted. Okay. So, this is the normal range of shouldering, but this has gone beyond that. So, there is an overshoot of the shouldering. And here, there is a flattened way, right? So, there is absence of shouldering. And here, it is just like a smooth trough. Okay. So, what is happening is, it is just coming like this and just going. Okay. So, there is smoothening of trough. And here, what is happening is, the thing is recovering. Okay. But the shouldering is trying to recover, but it is a late recovery. And if you see, there is in this one, there is a biphasic deceleration. Okay, two phases of deceleration are seen. The importance of this pictorial representation is that you have to remember that only the normal soldiering is a normal finding. Okay, whereas the rest of the things are considered to be pathological. Clear? Okay. Now, the CTG interpretation doesn't end here. We have to still discuss some more points. Okay. Trust me, I will make it easier. Yes. So, it is classified into category 1, category 2 and category 3 NST when we interpret clinically. But we have different terminologies adopted by ACOG and ICOG. ACOG says that category 1 is a normal, category 2 is a suspicious and category 3 is a pathological NST. Whereas RCOG suggests that category 1 is a reassuring NST, category 2 is a indeterminate NST and category 3 is a non-reassuring NST. Okay. So, these are different colleges, okay, that are providing guidelines regarding NST. This is a American college and this is a Royal College, which is UK and this is US. Okay. So, that is the thing. Right. Now, we will see category 1 NST features. So, category 1 NST is normal or yes, reassuring NST. So, we will see what are the features now. First feature, I said it is normal. So, baseline will be between 110 to 160 beats per minute. And what is the next feature we discussed? Variability. That will be between 5 to 25 beats per minute. And accelerations, see, ideally, remember, accelerations if present, then it is well and good. Okay. But if the accelerations are absent, it doesn't make the CTG a suspicious or a pathological one. Clear? So, accelerations can be present or absent. Then, about decelerations, early decelerations are also normal. We have seen that early. Okay. So, this can be also present or absent. And remember, there shouldn't be any late or variable decelerations. If you are confused with this, let me tell you about how the labor is going. When the labor is happening, what is going to happen? The fetal head is going to give all the push for the entire fetal torso to descend through the vaginal canal. Isn't or not? So, definitely there is going to be fetal head compression, and this fetal head compression is only going to be monitored more as early deceleration, right? So, anytime Even if you see early deceleration, that is a normal thing, right? But variable deceleration, which is happening due to cord compression, and late deceleration, which is happening due to uteroplacental insufficiency, or any times suspicious or a pathological one. Clear? Yes. Now, with this idea, we will pass on to the category 2 NST features. Okay. So, category 2 NST, which is a suspicious or indeterminate NST. Okay, we will see the features now. So, there can be tachycardia or bradycardia of the fetal heart rate. Okay, there can be minimal variability, okay, or even absent variability. Then there can be variable or late decelerations seen only if it is associated with moderate variability. Okay, we will be keeping it in second category. Then there are prolonged decelerations. Okay, that is more than 2 minutes but less than or equal to 10 minutes. Clear? See, all these things, put them in the category 2 NST. Next one, we are going to discuss about the category 3 NST, which is a non-reassuring NST or a pathological NST. Okay. So, what are the features we will have here? First point, it is definitely going to be a abnormal NST. Okay. There is an increased risk of fetal hypoxia and acidemia, that is going to cause neonatal hypoxic ischemic encephalopathy and cerebral palsy. And then features include, there will be absence of fetal heart rate variability. Okay. Then there can be recurrent, late or variable deceleration or a prolonged deceleration. And also we include the sinusoidal pattern of NST, the pathological type. Clear? So, these are the 3 categories of NST. Okay. Now, with this we are finishing NST. So, whenever you are going to your clinical postings, you just take the NST that has been taken in the labor room, in the OP or somewhere, and with every time you try to analyze all these factors, then only you will be able to recall. Okay. Yes. Next one, we are going to discuss about the biophysical profile. The components of a normal biophysical profile include, I have taken as man bat. Okay. Here I am keeping the A silent. Okay. So, these components include, number 1, M for movements. So, it is gross body movements. N for NST. B for breathing of the fetus. A for amniotic fluid volume, and T for fetal tone of the fetus. Clear? Okay. Now, we are not using this biophysical profile anymore because we have a much easier modified biophysical profile nowadays. So, we will see the modified biophysical profile components. Okay, this include only AFI and NST. Okay, because while measuring AFI, you are going to check the long-term placental function. Okay, and with the NST, you are going to check the short-term placental function. Okay, and also this is more advantageous because it is easier to do both or non-invasive procedures. Yes, and they are less time consuming also because we are measuring only two parameters, cost effective as well as there is no difference seen between the biophysical profile and the modified biophysical profile. Clear? Yes. So next we will discuss about fetal scalp blood sampling. So this is usually carried out if there is an abnormality in the fetal heart rate. This usually confirms acidemia or hypoxemia. The prerequisites for this procedure includes the cervical dilatation should be at least 4 to 5 centimeters, and also the vertex should be at least at the level of -1 station. Clear? Okay. Now, what we are going to do is we are going to obtain a lancet, What we are going to do is we are going to obtain a fetal scalp blood sample by using a lancet needle with the woman in the left lateral position. Okay. So here two parameters can be assessed. Either we can assess the pH of the blood or the lactate content in the blood. Okay. I hope you remember my previous explanation where we have discussed about the chronic compromised fetus status, how it goes. Okay. There will be acidosis and there will be accumulation of lactic acid. Okay, that's why we are going to check for the lactate. See, both the things need not be done. Either of the things can be done, either pH or lactate. Okay, but anyhow, I will tell you the reference ranges. See, the reference ranges are given as normal, borderline, and abnormal values. Okay, so normal range of pH is above 7.25, okay, and borderline pH is between 7.21 to 7.24, okay. Anything less than 7.20 is going to be abnormal. Clear? So for the lactate, levels below less than 4.1 millimole per liter is considered to be normal, because less lactate is normal, right? So when this increases between 4.2 to 4.8 millimole per liter, it is considered to be borderline, and when it goes above or equal to 4.9 millimoles per liter, then it is considered to be abnormal. Clear? Now, if it is in the normal range, okay, now what we have to do is, if it is in the normal range, we have to just continue monitoring, okay. Most of the times there will not be any need of a second fetal blood sampling, but if it is indicated by CTG, a second sample can be taken after 1 hour, okay. And if it is in the borderline range, then definitely have to take a second sample, but you have to take it much earlier, okay, within 30 minutes. Okay, then if it is in the abnormal range, then definitely you are going to expedite the delivery. Clear? So tell me what these instruments are. Yes, this one is a Pinard's fetoscope and this one is a handheld fetal Doppler device. Okay, so these are the instruments that are used for intermittent auscultation. Yes, we are going to discuss how to do intermittent auscultation during labor. Okay, so intermittent auscultation can be done with Pinard's fetoscope or a handheld Doppler or even a regular stethoscope. Okay, so what we have to do is the fetal heartbeat is heard through the abdomen of the mother, and even you can measure it for 15 to 30 seconds and then you can multiply it by 4 or 2 to get the fetal heart rate for 1 minute. So this is the recommended method of fetal assessment. So at what frequency you will be doing this intermittent auscultation? See, in the first stage of labor, intermittent auscultation should be done in every 15 to 30 minutes. Whereas in the second stage of labor, you have to do intermittent auscultation every 5 minutes. Clear? But there are certain drawbacks with this procedure. So drawbacks include it is difficult to do in obese women. Then it is difficult in polyhydramnios. Then it is not possible to differentiate between the various causes of decelerations. Clear? And I just want you to add some points on continuous fetal monitoring and what are the interventions you have to do when you get an abnormal CTG during labor. Okay. So with this, we'll be completing the discussion on fetal assessment, both antepartum and intrapartum. Hope this video has helped you. And until we meet in the next video, take care, happy learning and bye-bye.